Good evening. I'd like to welcome everybody here for the Monday, November 4th meeting of the Los Angeles City Health Commission. Can I ask for a roll call, please?
Commissioner Avila is absent. Commissioner Estradas? Commissioner Griffin is absent. Commissioner Hisarick?
Here.
Commissioner Cato?
Here.
Commissioner Calfani is absent. Commissioner Shannon? And Commissioner Sirota? And Commission President Mandel?
Present.
Commission First Vice President Grimmick?
Present.
Commission Second Vice President Asi?
Here.
We have a quorum.
Thank you, Clerk. I welcome you all here. I'd ask for approval of the minutes from September 9th meeting.
So moved.
Second.
Any discussion? Seeing none, can I ask for approval? All in favor?
Aye. Aye.
Anybody opposed? Abstentions? It's approved. Anybody from the neighborhood council here? Seeing no neighborhood council representatives, we'll move on to public comment. Are there any public comment cards?
There are not.
Well, it's a month of Thanksgiving, and I'm honored and thrilled to go to item number one.
Good.
Dr. Eckstein.
Commission President, do you want to close public comment then? Since no one's here, but just in case somebody comes in and wants.
I think if somebody comes in, we would accept public comment at the point in time, or at the individual agenda items as they come up. Item number one, Dr. Eckstein. We are thrilled and honored that you could take time out of your busy schedule to come to present to us.
Good evening. Thank you for inviting me. Privileged to be here.
The floor is yours.
Well, thank you. Good evening, everybody. I was asked to return. I think I was here perhaps a year ago or so, and basically the president posed some questions to me, which I put in this PowerPoint, but hopefully my goal tonight is not just to pontificate and read the slides. Hopefully this will be interactive and answer any questions you might have. Those who haven't met me before, I'm Dr. Mark Eckstein. I've been the medical director of LAFD for 24 years, bureau commander of the EMS Bureau, which was created in 2016. I've been a practicing emergency medicine physician for about 30 years, former paramedic. So I've been in EMS and emergency medicine my entire professional life. I think this is working. Oh, there it goes. There it goes. So much for decaf. So I'll just run through the questions that President Mandel posed to me. First question was, do you and your leadership believe the EMS is adequately staffed? And I'm a big believer in more is not necessarily the right answer, which all too often governments fall prey to. And we're trying to do things intelligently and recognize that the EMS system in Los Angeles, like the EMS systems pretty much around the country and around the world, changing in terms of their demands. So the EMS system, as everyone knows, was really created to address, to decrease death and disability from major trauma, heart attacks, strokes, car accidents, and things like that nature. But the 911 system has really evolved over the last 50 years to be really all things to all people, and they've really supplanted physicians making house calls. And consequently, the city of Los Angeles, like many cities across the country, have really struggled to keep up with the workload. The bulk of the increase in workload really has shifted to the lower acuity patients. So our challenge as a provider agency is to have our EMTs and paramedics, all of whom are also firefighters, available to respond when you or your loved one or a neighbor has a true time-critical medical emergency and not be tied up with the low acuity calls, which are better served in a clinic or care at home or through more effective preventive care. So with that kind of background, what we've done in being mindful of the shifting demands of the EMS system, the growing demands, and trying to be good stewards of limited healthcare dollars is we're trying to change the response model to provide the right service to the right patient at the right time. The traditional model of when folks call 911, we send engine companies and ambulances every time, and all roads lead to an emergency department or emergency room. It's clearly not the best fit for a large subset of patients. So we've created our own dispatch system. We used to have an off-the-shelf commercial dispatch system that was kind of a one-size-fits-all that's used in many 911 centers around the world. That was in place in the city for 25 years, and I was convinced that it was not the best fit for our community and our dispatchers and our deployment model. So in 2015, we implemented our own dispatch system, which was crafted to recognize time-critical calls much more quickly and send the right resources to patients and conserve resources so we have additional resources available for the next call because we've gotten so busy. We have gotten that dispatch system has proven to be very effective, so we're sending fewer resources per call, and we're sending paramedics much more frequently to calls that require paramedics, and we're sending EMTs to calls that only require EMTs. That so-called over-triage, which is sending paramedics to calls that only need EMTs, has gone down. Basically, it's been cut in half. It went from about 60% down to about 30%. So we're dispatching much more effectively, and we're also dispatching critical calls much more quickly. In terms of staffing, so rather than push to add more paramedic ambulances, I work with the fire chief and the city leadership to shift most calls that could be handled with what we call basic life support ambulances or EMTs to send EMT ambulances alone. And that has been a seismic shift. So we're now, what happened last year with that dispatch change, basic life support ambulance workload went up about 25%. Paramedic ambulances went down about 7.1%. So consequently, to address the need to address the low-level call load, we're adding 2 more EMT ambulances in April, so the third quarter of this current fiscal year, and we've made a big push to create what we call a mobile integrated healthcare unit, which is to send hybrid resources, which are nurse practitioners or physician assistants who are partnered with paramedics, who have a much wider scope of practice and much greater level of medical training to help individuals who don't necessarily need a ride to the hospital. So they could diagnose, they can write prescriptions, they could do wound care, catheter exchanges, and medically clear individuals who need detox, a sobering center, or mental health urgent care instead of taking them to an emergency room. So really the answer to that question is it's not adequately staffed, but I think we're being intelligent about it and saying what is the right staffing, what is the right complement of resources, and what are the right levels of providers to address the growing need. And I think we've been successful, and to demonstrate even more so that we're trying to be mindful of limited healthcare, limited taxpayer dollars. Just about all of our new resources in the realm of mobile integrated health have been implemented through public-private partnerships, whereby we have hospitals and hospital systems that pay for the salaries of the EMS advanced providers, and then the city pays for the paramedic, and we have donations for the equipment. So we've been successful in putting out 6 of those resources now, and these have really served as a model for the nation for other EMS provider agencies to follow suit. So certainly it'd be nice to be able to budget to get more of these resources, which are much more efficient. And again, it's marrying the right resource with the changing demand, then send fire trucks and ambulances to individuals who are hearing voices who need professional mental health counseling, as opposed to just take them to an ER that doesn't have those services. Do you want me to just continue through?
Yeah, I think the best way to go through your entire presentation, and then we'll open it up.
Okay, thank you, sir. The next question was, what are the 5 most significant problems in addressing EMS? And this was my own humble opinion. I think the increasing homelessness problem is disproportionately impacting the fire department in terms of our EMS response system. The statistics available indicate that 0.8% of the population of Los Angeles are homeless, yet the homeless constitute 13% of our EMS responses, and downtown about a third of our transports. So by a factor of almost 14, the EMS incidence for the homeless population supersedes their proportion in the population. So this poses a number of challenges. In addition to that, the likelihood of a homeless individual being transported is exponentially higher than anyone else who's housed, because our ability to direct them for follow-up with their primary care doctor, to a clinic, to other resources, really is not, those are non-existent. So for the most part, when there's a call for a homeless individual, whether a would-be Good Samaritan calls on their behalf or the homeless individual calls for themselves, invariably a very high percent of those calls, the patient's transported to the emergency room, when more often than not, they need wraparound services to address their social issues, substance abuse, and mental health counseling. So that problem, which used to be largely concentrated in the downtown area known as Skid Row, has now become a citywide problem. And the community resources that are available to help these individuals outside of Skid Row are few and far between. So that's, I think, the number one issue facing our EMS system in Los Angeles. As a segue to that, number two is a paucity of alternative destinations. And what I mean by that are federally qualified health clinics, or FQHCs, who treat patients irrespective of ability to pay, such as the indigent population or homeless population. We only have one sobering center in a city of over 4 million people, located in Skid Row, nothing at all in the Valley, Hollywood, or the West Side, and a paucity of mental health urgent care clinics. There's about 5 of those right now. There's only one in the Valley, which is at Olive View, which obviously is far to the northeast. And clearly that is a real challenge. So even when we have one of our new advanced provider response units that could medically clear an individual in a behavioral crisis, and they can transport them to a mental health urgent care facility, there's often one that's nowhere nearby. So that poses a significant challenge for us. And again, we're trying to shift the premise of taking these patients to an emergency room, because the emergency rooms, for the most part, cannot provide the services these individuals need. And to make matters even worse, as you might well imagine, the worst thing to do for someone with a mental health crisis, if we are trying to de-escalate them, is to leave them in the chaos of an emergency room, where they often sit taking up a bed for days until they could be transferred to inpatient psychiatric care, getting no mental health care. Number 3 really is a lack of an effective health information exchange. So the systems have gotten a little bit better, meaning the county hospitals now can communicate with each other. It's the same system. Kaisers can communicate with each other, but our electronic patient care records can't communicate with anybody else's. The counties, the private systems, hospitals can't communicate. So if we transport somebody, what we call an EMS super user, we transport the same individual hundreds of times, there's no central source to identify that amongst different hospitals. And also makes our ability to get patient outcome exceedingly difficult. So an HIE is extremely important, and that's a huge void in our system. Number 4 is a lack of case managers and patient navigators. And patients who are high frequency or high utilizers of the system, we call EMS super users, we have no system in place to try to coordinate their care, where they need intensive care in terms of social work or case managers to determine if they don't have insurance, can they get insurance such as Medi-Cal, and is there a place to get them plugged into a medical home where they can get wraparound services. And a high percentage of those individuals, again, are homeless, but it's difficult to coordinate the efforts with LASA and other agencies working with the homeless, and as a result, they have a disproportionate use of 911, unscheduled care in emergency rooms, which is really very, very ineffective and very, very costly. And then number 5, again, is a paucity of community health clinics. And I think this is most keen in probably the largest underserved community of South Los Angeles. So there's a huge economic disparity and huge healthcare disparities in South Los Angeles, and that's due to a lack of preventative care. So the biggest increase in our call load is in South LA, which is not from the homeless population, it's from individuals who have limited access to care. And that also reflects the fact that the community in those neighborhoods are sicker from what I call largely preventable diseases. So untreated or undertreated hypertension and diabetes lead to premature death. They suffer strokes, kidney failure, subsequent cardiac arrest, and the differences are striking compared to the wealthier communities that we serve. So clearly, I think the adage of an ounce of prevention is worth a pound of cure certainly holds true in our city. And if you look at the paucity of emergency rooms and, more importantly, community clinics for preventative care, that's something that's extremely important. And when we have a paramedic ambulance go out on someone who has a stroke, who's young in their 40s or 50s, and you see this individual clearly has had long-standing hypertension and diabetes that are untreated or undertreated, and now they have a devastating stroke. Aside from the human factor of their long-term disability, the cost to society is astronomical, where they are permanently disabled. They're in the hospital, they're in the ICU, they're in rehab, unable to work or provide for their family. So this is something that we can't do unilaterally as a city. We have to partner with the county and other services. But I think, in my opinion, those are the top 5 challenges in the system. If you notice, I didn't mention lack of funds. I think the funding is there. It's just how we allocate the funds that are available. Next question was, is the city adequately staffed for hospitals and hospital beds? So I'm sure, as everyone in this committee is aware, there's been a shift in the last decade, certainly the last 5 years, from inpatient care to outpatient care, which is a good thing. So we're admitting fewer and fewer patients, at least we try to, but the number of emergency department beds clearly is inadequate. Routinely, during weekdays, there's routinely at LA County USC Medical Center, where I've worked as a physician for 30 years, there's about a 12 to 18-hour wait to be seen, which is, I think all of us would agree, is unconscionable. Last week, and this is before we're hitting the flu season, there was, other than the fires, there was no medical crisis. There was no epidemic, no flu outbreak, no mass casualty incidents. We had no open beds in the hospital for days. So a patient comes in either by walk-in or by ambulance, and we treat them, and they need to be admitted, and there's no beds upstairs. That patient stays in the emergency department for hours or days. More ambulances come in, the paramedics can't offload, everything backs up. And if you go into a work week on a Monday with no open beds in the hospital, that's going to be a real problem. So I think perhaps this pendulum has swung too far, that there's not enough hospital beds and not enough emergency beds. But the caveat is a lot of those patients who end up in the ER don't need to be there if we had adequate preventative care. The next question was similar to, is there adequate hospital capacity for a minor catastrophe? And obviously it depends how we define the phrase minor catastrophe, which is kind of an oxymoron. If it's a catastrophe, it's probably not minor. But in terms of minor multi-casualty incidents, we deal with those every single day. And I think the city and the county is very well prepared and very well versed to deal with these. In terms of bus crashes and car accidents and multi-victim shootings, we see those day in, day out, and those are less than 10 patients. So the city, I think, is the healthcare system is robust and able to respond quickly to accommodate those patients. I think that's been very, very effective. We're bringing a lot of resources to bear in the city, and we're able to take those patients to trauma centers and more distant hospitals, and we've demonstrated we do that very, very well. In terms of a major catastrophe, again, really depends on the definition. So clearly, if there's an earthquake, that poses problems because your infrastructure is impacted, and certain hospitals may be closed or have to transfer patients out because the physical plant may not be stable, or they may be without power or water. Barring an incident like a major earthquake or a brush fire overtaking Olive View Medical Center, which has happened several times or been close to happening, in terms of other patient generators such as plane crashes and train crashes or flu epidemics, I think for the most part, or heaven forbid, a terrorist incident, we've been able to respond very, very quickly. Unfortunately, we've had a fair amount of experience over the years. We really are very self-critical. We do what we call after-action reports, and we do a comprehensive analysis of the incident, what we did, what went well, what we could have done better, lessons learned. We publish those things in peer review, and I think we do better each time. And when we have a lot of critically injured patients, the system's able to absorb those and provide excellent care. We've had probably the two best examples of that are the two Metrolink train crashes. The first one, which I think was probably 12 or 15 years ago on the border of LA and Glendale. Things that go as well as they could have. We did a very comprehensive analysis. We learned a lot. And then part two, if you will, was the Metrolink train crash in Chatsworth, which had a lot more, many more critically injured patients, and we did very well, even though that was a more challenging incident because it was in a remote area of the city, 5 o'clock on a Friday. We used helicopters and we spread the patients out. And the good thing in terms of measuring success, there were no patient who was alive when we pulled out of those trains, and I was on scene for both of those incidents. None of those patients that we pulled out alive died. One with severe head injuries from the second crash never woke up. But I think clearly we handled those pretty well. Flu epidemic is a different story. When we've had 2 years ago, we had a pretty bad flu outbreak nationwide, and those severely impacted hospitals, the EMS system. People don't listen to the admonitions to stay home, don't go to the ER. There's not much we'll do for you. You're just going to expose other people and really crash the EMS system. People don't really listen to that, and we were severely challenged because the hospitals were full, the ERs were full, paramedics couldn't unload. The system was really taxed. So we kind of collectively hold our breaths, and hopefully it won't be a very particularly severe flu season. But clearly, that's something that every few years really challenges our ability to absorb patients, because that's as opposed to a single incident like a crash that's drawn out over months, and then those patients tend to be hospitalized for longer periods of time. So that's more difficult to respond to. The next question was about the EMS budget. I don't think the EMS budget is sufficient, given the fact that as an EMS provider, the fire department has become all things to all people. So unless there's a criminal element to it, all roads lead to the fire department. So if you're hearing voices, if there's a cat stuck in a tree, if there's a rattlesnake in your garage, if you don't feel well, if you ran out of your medications, if your blood pressure is high, people call 911 and we respond. And until we rolled out these new resources, which are still relatively few, other than taking their blood pressure, take them to an emergency room, we don't have much to offer them. So in terms of our strategic plan and looking ahead, I think we're doing better. But in terms of being intelligent, such as caseworkers, social workers, augmenting our specialty resources like advanced provider response units or SOBR unit, I think that would be money well spent. And those resources right now operate only on a 410 schedule, and we need those certainly, if not round the clock, at least some nights and weekends as well. As an example, with our SOBR unit, which has been very successful, that also was a public-private partnership with Exodus, which is a operation run under the auspices of Department of Health Services. Historically, we go on a street inebriate, most of whom are homeless, most of whom are EMS super users. All we can do is check their blood sugar and take them to the emergency room. If they have evidence of any head injury, they end up in the trauma center getting repeated testing, very expensive. The paramedics would have to hold the wall with these patients for hours, and they would basically stay in the ER until they sober up, which takes often 10 hours. Now we have advanced providers, or the SOBR unit has an advanced provider. They medically clear them, take them to the freestanding sobering center on Skid Row and say conserve resources, and the sobering center tries to get these individuals to accept their offer for detox and transitional housing to break the cycle. I'm very pleased to say we've transported, the sober unit alone has transported over 1,100 patients to the sobering center to date. It's gotten national notoriety. We got the Community Service Award, which is a national award. It's been covered on NPR and a number of other national media outlets, and I think it's been a great model. Limitation, it only works 3 12-hour shifts a week, but when it's operational, it's been highly effective. And of course, the other rate-limiting factor is the only sobering center is downtown, so it would do no good to put a sober unit up in the valley because you don't want to take these individuals that far. So we're on the right path, but clearly it's not just putting more of the same resources, but what resources can we add? What administrative support do we need to try to address these growing challenges? Bottlenecks in the system, I alluded to some of my opening comments, is the increase in call load for low acuity patients. And if you think about in your community, you have a fire station in your community that if you have your moment of crisis and you call 911 because your loved one has a medical emergency or your house is on fire, it'd be a difficult pill to swallow to think that that engine company or that paramedic ambulance is not available because they're going to somebody for the umpteenth time who has a drinking problem, substance abuse problem, or just doesn't want to take their medications. And clearly, that increase in call load for the low acuity patients has been very, very challenging. It's gone up probably 50% in the last few years. I mentioned the call load for the homeless patient. Again, it's less than 1% of our population, over 13% of our transports, and over a third of the transports downtown, which is very, very challenging. And again, the paucity of alternative destinations. So I think those are the bottlenecks. But the mantra of simply transporting everybody to the ER not only is not cost effective, it's not the right care for a lot of our patients. Are all communities equally served? Clearly not, as I alluded to a little while ago. There's huge similar to the income disparities in the city, there's huge health disparities. And it's probably the most sobering statistics. If you look at the average age of our cardiac arrest patients in South LA, they're often individuals in their 40s and 50s. And you look at that in the Valley and the West Side, these are individuals in their 70s, 80s, and 90s. And it's just most of these individuals are going down with, again, preventable diseases, particularly hypertension, diabetes, tobacco use, substance abuse. So the lack of CHCs, hospitals, and other resources in the healthcare community, particularly in South LA, I think has been a huge challenge. And we keep throwing more ambulances at the problem. We have some stations now where we can't even accommodate more resources. Skid Row, the Fire Station 9, for example, which is an older station, we currently have a fire truck, two fire engines, two paramedic ambulances, an EMT ambulance, and a fast response vehicle, and they're running, and that district is 1 square mile, which is our smallest district in the city, and they're running an average of 70 calls a day. So at a certain point, you have to say, wait a minute, maybe we got to try something different. But I think the city and the county, we better serve spending more money on a preventive health clinic and detox center and augmenting sobering services on Skid Row, and basically having more ambulances take people to county hospital, to the ER. It just doesn't make a lot of sense. Follow-up question was costs. So as I'm sure this commission is aware, the county sets a ceiling on costs for ambulance charges. Many of our constituents are unaware that if they are transported by ambulance, they are billed for those services. We currently do not bill if there's a response with no transport. So we currently only bill for transport to an emergency room. If it's basic life support, meaning EMT level care, the current bill is the current charge is $1,030. If it's ALS or advanced life support care provided by paramedics, the current charge is $1,452 plus $19 a mile. And that's probably the lowest rate in the county. other jurisdictions charge about $2,500 for the ambulance transport as opposed to $1,450. So that's the charges. Those charges were last stipulated by the council back in 2014, so they're woefully out of date in terms of the consumer price index, particularly the health price index. So I would imagine they're going to go up when they're reevaluated. I believe it's probably this coming year. In terms of the payment, we collect a little less than 50 cents on the dollar. Medi-Cal pays the least. Medicare pays is the next best payer, and commercial pays the most. And obviously, if you have no insurance whatsoever, it was what's called self-pay, collect maybe $35 on average for an ambulance transport. As you might imagine, the commercial payers, the percent of commercial payers has gone down. Medi-Cal and self-pay has gone up. And those charges are based on formulas for full cost recovery because we have to be cost neutral. So we can't make a profit as a city. So they calculate the direct and indirect costs and cap costs, and those were the charges they came up with 5 years ago. But again, most communities in the county charge closer to $2,500 versus $1,450. So there's an opportunity to collect a lot more revenue there. And obviously, if there's an economic hardship for individuals to pay, the billing company takes that into account. There are nursing homes or extended care facilities that appear to be abusing MS services. So I'd be careful with the word abusing. I think to some extent the answer is yes. Part of it's liability from those facilities. Most of them have been very reticent to work with us in terms of preventative care. And I think there's some opportunities to leverage technology such as telemedicine to address these ongoing issues. But the answer to that is definitely yes, that we have a unnecessarily high number of calls and transports from certain facilities, particularly in the San Fernando Valley area, that generate way too many patients, and it's often not in the patient's best interest to take them from their extended care facilities and nursing homes to an ER. They tend to decompensate very, very quickly. Then I want to spend the next few minutes just going over a little more detail what I alluded to in some of my comments and what we've done in terms of the fire department's approach to address the accelerating use of 911. And that graph you have in front of you on the handout and the overhead shows pretty clearly the increasing EMS call load year over year. Talked about the impact on Skid Row, and that's obviously no surprise to anybody. Again, I talked about an average of 70 calls. That sometimes spikes up to 100 calls a day just in Fire Station 9's district. Things like spice, which is a synthetic marijuana, will have sometimes 10 or 20 patients go down using that substance, which also is a risk for our providers because the patients are often combative. We've also had both first responders and law enforcement, firefighters and paramedics contract communicable diseases from that population. So clearly we need a much more comprehensive approach to deal with the thousands of homeless individuals living in squalor in that community. As I mentioned, in the EMS Bureau and the Fire Department, we created a mobile integrated health unit, which is a compilation of innovative resources to provide the right service to the right patient. These largely consist of what we call, again, advanced provider response units. These are EMS APs who are physician assistants or nurse practitioners partnered with paramedics. Again, their mission is to treat and release low acuity patients to avoid unnecessary ambulance transport to an emergency room. Medically clear patients, they could be transported to a mental health urgent care clinic or a sobering center, and also try to identify and provide help to EMS super users to navigate them to medical homes and decrease their reliance on the 911 system. We currently have 5 APRUs. We're hoping to add a 6th. That doesn't include our sober unit. Again, these have been very, very successful, and it really served as a model that many other provider agencies and fire departments across the country are trying to emulate. As I mentioned before, in terms of being cost effective, these have been funded through collaborative efforts with the private entities you see there. Kaiser, Providence, Cedars, and Dignity have been great stakeholders with us and provided funds. which covered the cost of the salary for the EMS advanced providers, and the city funds the cost for the paramedics. As I mentioned, they have unique capabilities and a much wider scope of practice than paramedics. EMS super users are very, very difficult. That's where social workers or case managers would be extremely helpful. I can recall a conversation I had with the former CAO of the city several years ago, and we talked about the need to fund these efforts. And I was there meeting with him and the fire chief, and he said very clearly, well, this is a problem for Department of Health Services, not for the city. And I said, well, all due respect, whether we like it or not, this is our problem. And do you want $1 million fire trucks with 6 firefighters going to someone in the street who's drunk in public or hearing voices, or do you want preventative care and get these individuals the help they need and free up resources? So again, it goes to preventative care. So it's been a challenging road to get these funded, but whether we think it's our responsibility or not, the reality is we own this problem, and we have to deal with it. In terms of being innovative as well, the California law currently does not allow paramedics and EMTs to transport patients anywhere other than an emergency room. And that was the genesis of us creating advanced provider response units where PAs and NPs can medically clear patients, transport them where they want, or safely treat people at home and not take them anywhere, like as an ER. So I was able to get approval through the state with 2 state-approved pilots for what we called an alternative destination response unit. So now we have 2 paramedics that we provided additional training to. They respond in a non-transport vehicle, and they do what the advanced providers can do, and they could medically clear mental health patients and public inebriates and have our ambulances transport these patients to mental health urgent care facilities or sobering centers. So this is still fairly nascent. They've cleared about 40 or 50 patients so far. Again, it's a proof of concept under the auspices of the state, and we're very optimistic we'll be able to expand this, and hopefully the legislation will change to allow paramedics with proper training and proper medical oversight to expand this concept. I think to really underscore how the law is so overly prohibitive and nonsensical, a LA PD officer right out of the academy who's 21 years old, who has CPR training as the extent of their medical training, can go on someone right now, apply a 5150 hold, and then transport them to a mental health urgent care facility. But a 30-year paramedic with 1,500 hours of medical training cannot. So pretty hard to reconcile that right now. So we're trying to be a little bit creative, and we're hoping that the legislative bodies and the electeds will allow the law to reflect reality and help a lot of these very, very vulnerable patients. I mentioned our SOBER unit, which stands for our Sobriety Emergency Response Unit. Again, public-private partnership. We have a nurse practitioner. We have a case manager, both of whom are employees of Exodus, and they're partnered with one of our paramedics. And they, for the most part, cover Skid Row. Again, over 1,100 patients safely cleared and transported to the sobering center. And we've had some real victories there. We've had a few individuals who've used 911 with hundreds of transports over a few year period of time who we transported to the sobering center, who have entered detox and transitional housings, and those have been some real success stories. And obviously, they free up our paramedic ambulances and open up the ERs for patients who need those types of services. So a lot of information in a relatively brief period of time. Hopefully, I answered the questions you posed, and certainly happy to answer any other questions that you might have.
Thank you. Thank you for such a thorough and comprehensive overview of what you do and what your department does. I truly appreciate you coming today. I would say that this entire commission believes in what you're doing and the vision you have to improve the system, and you should count on us to assist you in any way that we can if you think that would be beneficial with our relationship with the City Council. I'll open up to questions.
You're talking about opening up more preventative health clinics and sobering centers. Most of that would be funded by the county?
So it's a great question. So the fire chief and I have been meeting with leadership from the county, the director of Department of Health Services and director of Department of Mental Health, DMH. And what's been particularly frustrating is you look at the funds from measure, Triple H and H, where there's almost $1 billion that have been goes towards funding. I know some of that is for structures, facilities. Some of that is for staff, but the progress has been painfully slow and inadequate. And I think, yes, the combination is FQHCs, sobering centers, and mental health facilities. In terms of who would pay for it, it really falls within the purview of the Department of Health Services. And the best example is when the former DHS director, who since left, he came from San Francisco where they had a very successful sobering center. He created the sobering center downtown, and when it opened up, they didn't have enough patients. And as soon as that opened up, we said, hey, help fund this, help provide us some staff. We'll have a mobile sober unit, and we'll send you patients. So it's been a great collaboration. I don't think the city should take on that role of brick and mortar building those structures, but we'll provide the resources to safely identify patients and transport them to those resources. But if you think about the population of the valley, which is probably 1.5 million people, which would be probably one of the largest cities in the country alone, and the only facility that comes even close to that is a very small mental health urgent care facility at Olive View, which has about 6 or 8 beds. It's an abomination. And you look at the homeless problem in the valley, it's ridiculous. And then as a physician, I see our paramedics roll on someone who's suicidal. We take them to an ER. Those ERs have no mental health services, none. So the emergency physicians, we medically clear them. We wait for them to be put on a 5150 hold. They need an inpatient psych bed. There's a huge shortage of inpatient psych beds. They may sit in that ER for 3 to 5 days, totally escalating, getting no mental health services. And then when you have a sick medical patient, that bed's tied up. Our research has shown when we're able to medically clear these patients with our advanced provider units and take them to a mental health urgent care facility, such as which are mostly run by Exodus, they get mental health counseling within 25 minutes of them hitting the door. In an ER, it's almost 24 hours. So to answer your question, I think the city leadership needs to put more pressure on the county and say, we need to collaborate, open these facilities. I don't think we should be building facilities for the homeless that don't have co-located detox and mental health services. Having worked at County USC as a physician for 30 years, the overwhelming majority of homeless patients, and we own Skid Row, they all go to County USC. Overwhelming majority of homeless patients I've taken care of there over 30 years, thousands and thousands and thousands, have mental health problems, substance abuse, what we call dual diagnosis, which is a combination. You can't put someone like that in an apartment and expect them to function. They need intensive wraparound services, which is mental health counseling, detox, and then take care of the social issues and housing. And I think it's very short-sighted to think it's just about housing. So, and I think the community is frustrated as well because based on the definition of 5150, which includes gravely disabled, in my opinion, a sizable percentage of homeless patients down the street from here meet that definition. They lack capacity. The law right now is very difficult to conserve somebody against their will for 12 months. There's a huge shortage of inpatient psych beds. So there's no easy fix, but I think when we talk about the homeless problem, which is arguably the biggest problem confronting the city right now, I think it's very foolish to talk about housing without talking about supportive services. The two have to go hand in hand, and we have to make it financially attractive for hospitals to augment their services, to put mental health services on the campus, so which overcomes a NIMBYism. Nobody wants these structures in their neighborhood, but if you put them on the campus of an existing medical facility, that would help. Or places we're already putting bridge housing put a sobering center and mental health urgent care facility there. I think those are the answers, which requires money and staff and leadership. But I just think we have to be smart about this. But if you think about 0.8% of the population is homeless, but it's 13% of our transports and a third of our transports downtown, that's just not sustainable. That's absolutely not sustainable. So I think it's a question of who pays for it. It largely falls on the purview of DHS, but whether we like it or not, we're having to deal with the fallout.
Okay, thank you.
Thank you.
Regarding, when you talked about first of all, I'd like to say thank you so much for this outstanding report, very informative. And I think this report is also going to help us with our Health Commission report. It would have been great to have this information, but we can talk about this later, that we could maybe make some adjustments or additions to our report.
It's our plan. Our plan is to include it, and one of the reasons we wanted the doctor to come today was so that we could have it for this year's report.
Great. Thank you so much for your report. Regarding the 5 most significant problems, a couple of them had to do with lack of effective health information exchange. Are you familiar with the LANES program? That's the Los Angeles Network of Enhanced Services, Electronic Medical Records. It's a new program that started. There's healthcare providers that are participating in this. UCLA, USC, LA County USC Medical Center. Some of the FQHCs, it would be great if the LA Fire Department EMS Bureau would be involved in this so that you would have access to electronic medical records.
Well, thank you for that. We'll certainly look into that. Certainly, we need to be able to communicate with all the hospitals, be able to communicate electronically when we get a hit on the same patient. So we'll certainly look into that. I know there's been different efforts. Hasn't been very well coordinated with all the different entities, but we'll certainly look into the LANE program.
Okay, great. And the other was the positive community health centers. At first I thought maybe it was LA County Community Health Centers, but you mentioned FQHCs.
Yes,
and yes, I agree, there is a need for more FQHCs. FQHCs tend to be open 5 days a week, business hours. Some of us, I happen to work for an FQHC, I serve at an FQHC that serves District 1 and 14, are open 6-7 days a week, evening hours. And I hadn't thought about this before, but this is a wonderful opportunity to collaborate with you. And I would like to ask our Association of Community Health Centers to invite you to give a presentation at our FQHC clinics to see how we can enhance and improve collaboration with you and work with you. The other was the urgent care centers, because as I'm listening to you, there's patients that may not need emergency room but urgent care. They need more than community health center but urgent care. How is the collaboration and working with urgent care centers? I know there's not enough urgent care centers, but are you working more collaboratively with urgent care centers?
Thank you for your comments. To a limited extent, we are. So our advanced provider response units basically is for lack of a better term, is a mobile urgent care. It's urgent care on wheels. Yeah. Obviously, if a patient needs imaging, so they've had portable ultrasound at times, but if they need x-rays or CT, obviously, the patient, they'll typically, they can call for a yellow cab through donations we have and then have the patient transported to an urgent care facility. But to your point, I think it's a combination of all those things. That there has to be capacity and round-the-clock availability of FQHCs, urgent care centers. And when I say clinics, it's really both. The providers that staff the clinics not only should be able to manage their diabetes and hypertension, but could handle the low acuity urgent care problems such as a sore throat and minor lacerations and UTIs and so forth. And it's been still too many of these people ending up in the ER.
Yes.
So it's slow to move the needle, but globally we see I think the health disparities, particularly in South LA and East LA, but particularly in South LA, the human toll is it's unbelievable. And I've worked at hospitals in those communities, and the toll, particularly of hypertension and diabetes, it's treatable. Combination of inadequate diagnosis, inadequate access to health care, health education, medications, diet, and so forth. The human toll is devastating. The cost is astronomical. So I think, to your point, it's really a combination, but it really points to the need for a comprehensive strategy. And I think the city needs to realize that we're in the healthcare business. So the LAFD is the largest provider of unscheduled health care. Actually, we're the second busiest in the entire United States. And we can't just say, well, that's the county's job, that's the county. DNH, DHS. No, we have to be smart about it because these are our fellow community members.
Yes.
And it takes a collaborative effort. But the fire department was never designed to run on the calls we're running right now. The majority of calls we run on, not only don't they need paramedics, they don't need EMTs, they don't need ambulances. They need something else, but these people don't know whom else to. They know if they call 911, some red vehicle will get there pretty quickly, and if nothing else, they'll take them to an ER, if nothing else, which obviously is not the best solution.
I was really pleased to hear about the Advanced Provider Response Unit, and would like to have more information as you have more experience with this. Would you please elaborate on the difference between that and the mobile integrated health, specifically mobile integrated health?
Yes, so mobile integrated health is a fairly new term that talks about the change in role in EMS, where different levels of EMS providers take care of people and treat and release them on scene, or do preventative care, or transport them to alternative facilities like mental health facilities or sobering centers, as opposed to just taking everybody to the ER. So that's under the umbrella of what's called mobile integrated health. Under our mobile integrated health unit, we have these advanced provider response units, we have a sober unit, and we have this new alternative destination unit. So anything other than the traditional transport to an ER, that's under the umbrella of mobile integrated health. So for example, if someone calls 911 very, very frequently because they have brittle diabetes, for example, or they have COPD, it makes a lot more sense to send a unit, an EPRU there once a week to make sure, do a wellness check, make sure they have oxygen or the meds they need, and send fire engines and paramedics, take them to the ER 3 times a week, and they end up in the ICU. So that whole realm of that preventative care, non-ER transport aspect to EMS is mobile integrated health care, or mobile integrated health, and the APRU is one of the resources under MIH.
Great, thank you.
Thank you.
Excuse me, thank you for your presentation. I always enjoy it. Pardon me. The nursing homes and extended care facilities, I know some of them are frequent users, and they have very little capacity to do resuscitation, for example, within the nursing home. And I know that sometimes it's called the fire department because somebody's fallen out of bed. And I mean, that seems inappropriate. And what alternatives are you working on to improve that? And who gets billed, if anybody, when that occurs?
So great question. So the example you gave of someone falling out of bed or falling from a wheelchair or a chair, which is common, we'll send a resource, and we will evaluate them for any injuries, and if there are none identified, we'll just put them back in bed, and there's no bill generated, because currently the law only permits us to bill for transport to an ER. A solution to that we're working on now is working on creating a telemedicine program as a pilot program next year. There's been some pilots around the country that have been successful. One of this, specifically the patient population you talk about, where you have ground level falls at these extended care facilities or nursing homes or skilled nursing facilities, and you do telemedicine with a physician, and they could say this patient does not need to go to an ER. So programs like that are able to leverage technology, they're cost effective, it's better for the patients and better for the next patient whose response might be delayed because the ambulance is not available.
Yeah, one of the questions, of course, has been, are there legislative remedies to getting these facilities to beef up their capability? But you can't do that at a city level because they're really controlled by state regulations. But I know it's been a subject ongoing with various folks because I live not too far from a couple of nursing homes, and I know they're down there all the time for, I don't know what, but presumably resuscitations or falls and so on.
Well,
It
I will
does tie
say-
up resources for a while, though.
Yeah, I will say, I'm sorry, what has gotten a lot better with the change in legislation is the patients at these facilities are required to have advanced directives now, what we call pulsed forms, physician's orders for life-sustaining treatment. So we could paramedics could rapidly ascertain if the patient's a full resuscitation or a DNR or somewhere in the middle,
Right.
which that's been a very positive change. But to your point, the only way to change that behavior is through legislation that has financial penalties. The worst case example of that was the 911 call that went viral where the provider or nursing home said, we can't do CPR, it's against our rules for liability purposes. So there clearly is some low-hanging fruit, but it's like automatic alarms. Unless there's a financial penalty for abusing the system, it's easy to just have paramedics go and take care of the problem.
Yeah. Thank you.
Thank you.
For your presentation. And I did have a question, though. In regards to federally qualified health centers, what is your proposal, or what were you thinking about in terms of that partnership? I wanted to make sure I understood them as an option. And I think FQHCs, depending on what district you're in, you have more and others. So in South LA, I used to work for an FQ in South LA. So you kind of saturated with FQs in South LA. But curious of the partnership you are thinking about in terms of how to use them, because you do have some FQs that have integrated behavioral health within their systems. You have others that have also integrated substance use disorder programs within their system, so it's patients more at a low level in terms of care. But in terms of hours, right, you have most health centers that are probably going to close by 7:30, 8. They will open on the weekend, but those hours are going to be limited to maybe by the afternoon, or if you're lucky, some may be open till 3. And so just trying to understand what that could look like. And also, I think there is an issue with how information is shared, because not everyone is on lanes, and so it is, how do you communicate with the patients that is their medical home? How do you actually get them to their medical home? And then folks showing up, or either showing up in ER or calling 911. I think there's also just a struggle with how people navigate the healthcare system. And so you do have an experience, so many folks that will call 911 because they either feel like they can't get into their medical home or their health center when they want to be seen. It doesn't mean that they may not get seen right away, but it's just easier for some to feel like, well, let me just call 911, when they should really be working with their medical home. And so there's, patient education that's related there. But then there's these other issues that are happening in communities that go beyond just patient education, in terms of other access that impact health disparities. So that's, a whole separate issue. But because I do think there could be and should be an opportunity with federally qualified health centers in partnership with the county as well. But curious about what you are thinking and what has possibly been tried already.
Well, thank you for your question. Ideally, everybody would have a medical home. Just like if you have good health insurance, you pretty much know who you have a primary physician, a primary care provider. And the frequency with which I see patients, particularly in South LA, who just run out of their medications, or they don't know who they could follow up, so they end up calling 911. So I think that system needs to be strengthened. Part of it's education, part of it's outreach, part of it's accessibility. There should be a hotline for someone to call that might obviate the need to call 911, whether their child has a sniffles or they're about to run out of their blood pressure medicine. It should be fairly easy to get a walk-in appointment, you get an appointment or a walk-in to get a refill. And again, for prevention. so I think there's been progress, but not enough. And you look at ironically, you look at the end result. I mentioned stroke as a devastating result of untreated or undertreated hypertension and diabetes primarily, and there are no comprehensive. The comprehensive stroke centers closest to South LA is Good Samaritan Hospital downtown, or Torrance Memorial in Torrance. There's no comprehensive stroke center anywhere in that community. Yet we have a plethora of them in other parts of the city. Yet the community in South LA is disproportionately affected by stroke as a sequelae of hypertension and diabetes. So I just think that there has to be a much more of an aggressive, proactive approach, which again is not trying to be overly simplistic, because it's not easy, but everyone needs to know they have a primary care provider, or they have a number to call that's not 3 digits. That's a hotline to call, just like Kaiser has a nurse triage hotline, because they're trying to have their members not call 911 when they don't need to answer healthcare questions, or electronically. They should be able to call if I need a refill of my hypertensive meds, and they punch up their member number, and they should be able to electronically call in a prescription. So I think that needs to be strengthened, but it's not just the inappropriate use of 911, but the biggest toll is calling 911 when it's too late because these diseases were not treated appropriately. But I think the FQHCs play a role, but I think they could play a much, much greater role, particularly in the underserved communities.
I would recommend, similar to what had already been shared, is talking with or meeting with the folks at the Community Clinic Association of Los Angeles, which really is the body, the association for FQs and community health centers in LA County, and really our partners throughout the city. So I would say, in terms of deepening a partnership and relationship, is really connecting with that association and presenting and figure out ways to really, to improve communication, as well as having them hear really what the experience is and what they can do on the other end to help.
And I think, ma'am, probably the most compelling statistic, because I threw some statistics at you, and there's a lot more statistics. More than half of our ambulance transport involve no treatment whatsoever. Well, much higher than half. We basically take someone from point A to point B being an ER. And it costs us $1 million to put a new ambulance in service. $1 million per year. There's got to be a better way. So, the ambulance should be there when you're having your crisis. They should be able to get there very quickly to save your life. But the bulk of what we go on is, for a number of reasons, shouldn't be in the 911 system. And I think people either don't know, or they don't have access to alternatives. And I think that would be money well spent.
So my question is related to your city-county dual response. How often does LAFD experience a dual response with county EMS and city EMS, and how does that impact your budget?
So there's border districts in the city where the city borders county, where we'll respond together. County fire does not have ambulances. They have paramedics in squads, which are like converted electricians' trucks. And they have private ambulances that cover different communities. So it's pretty seamless because it only impacts certain parts of the city. If the location is in the city, then we respond. But we changed policy based on some bad outcomes several years ago, that if our units are dispatched and they determine the address is actually in the county, not the city, they have to continue through. They could ask dispatch, say, hey, it's in the county, you dispatch county fire, but they can't assume someone else is going. So on the EMS side, it works pretty well. There's usually whoever gets there first cancels appropriate resources. And then with fire, there's mutual aid. But there have been some highly publicized incidents, I think was highlighted by the LA Times several years ago, that showed people living in certain border communities, particularly certain parts of South LA. There's a county fire station across the street, city fire station 2 miles away, and they had to wait for city resources. I don't know if that problem has largely been solved, but I know that we have a policy that if if our members are responding and they realize, hey, it's a county address, it's still your incident, you can request the county to be added, but you can't cancel until someone gets there and say they'll handle it. So it hasn't been a big problem for us, but the whole 911 system clearly needs to be modernized, which is a nationwide problem.
So does it have a huge impact on your budget, or not really?
Well, the issue you specifically asked there's really no issue on the budget. The bigger issue is modernizing the entire 911 system, which is a nationwide problem. That's a major budgetary issue. We only, as a department, we only got the technology where we know where our resources are. We only got that about a year and a half ago. Otherwise, we were relying on people in the field to manually punch in on the computer where they are, which is a leap of faith and often inaccurate. But the technology to order Uber or Lyft is light years ahead of almost any 911 system in terms of getting the closest resource, in terms of getting the caller knowing the ETA, seeing an icon on the screen. Our ability to determine your location if you call on a cell phone is still work in progress. It's coming, but we still have to give me your address, spell the street name. Is that in downtown? Is that in the harbor? The dispatcher has to look for the nearest cell tower on the screen. What's the nearest cross street? So it's a very archaic system. The technology available to order a pizza is light years ahead of almost any 911 system. So there needs to be a huge capital investment to change that. It's happening, but very, very slowly. Again, our automatic vehicle location, or AVL, was only put in fairly recently. But if you think about the technology to order a pizza or rideshare, comparing that to ordering, 911, it's like the dark ages. I mean, it just is. That needs a major, which probably requires a bond, a major overhaul. You have a system based on an analog-based system as opposed to something that's based on the cloud or GPS coordinates. So the GPS-based location is coming through an outside vendor, but it's been slow. And then, of course, where the resources are. So the technology in 911 is woefully behind, and that impacts our ability to process the calls and send resources when lives are on the line. Not unique to LA by any means, but it's quite palpable because, again, the technology that businesses have, particularly for rideshare and delivery service, we're nowhere near to that. I mean, you order a rideshare, you're not typing in or telling an operator where you are. They know where you are within a few feet. We don't have that yet. It's coming, but not yet. So a lot of challenges.
So I just have a quick question, and thank you for coming and sharing this information with our group and coming here after, I'm sure, a long day, so we appreciate it. Following up on a couple of the comments on FQHCs, where do you see the cities where would make the biggest impact as far as places where you don't feel there's adequate resources to place FQHCs? What are your top few that you feel like if we had places in these areas, it would help what you're trying to do?
So thank you. Great question. I'm sure to no surprise to anybody here, it's the most economically underserved areas. So Skid Row, the South LA, East LA, areas where the largest concentration of homeless individuals are. I mean, if you have good insurance, you don't need an FQHC. So if you do a heat map, and we have it, GIS mapping, where the largest concentration of homeless individuals are, or census tract based on areas with the largest number of people living below the federal poverty line, that's where you need these clinics. And that's where we have not only the highest 911 usage, but the greatest spikes and increases in 911 utilization. And again, the spike in South LA is not from homeless. It's just it's a very sick population with inadequate access to care. And the irony, as I mentioned before, is just it's so much more just from an economic perspective, it's so much more cost effective. You think about the fact someone runs out of their meds, they get a headache because their blood pressure is high, they call 911, they're generating a $1,500 bill for the for the paramedic ambulance. They're generating probably a $2,500 bill minimum for the ER. That's already $4,000, as opposed to the urgent care bill for them for a scheduled appointment, it's probably $100. So I think the areas with the greatest health care disparities and economic disparities in the city is where the greatest need for FQHCs are.
The truth of the matter is, a lot of those people aren't paying for it. So it just goes into your budget or gets cost shifted onto other people who pay, which is one of the problems of it.
Well, the taxpayer, someone's paying for it.
Right.
And even if they're not paying for it, the truth of the matter is that money's not being spent elsewhere.
Right, exactly. You mentioned super users, and clearly that's, that's a cost to the whole system. How many super users do you think there are in the city of Los Angeles?
So the first, can't answer that unless you define super users. There's different definitions of super users. Some definitions is more than 5 911 calls a year, others is 15, 20, 25.
Let's say 20.
I mean, the last time we ran this data, about 3 years ago, our top 40 super users accounted for over 2,000 calls in 1 year. It's a lot of calls. It's also a morale killer for the field. Stations that are busiest, where the guys and gals are getting throttled, running 15, 20 calls in a shift, 5 after midnight. If they get 3 in the morning, someone's having a heart attack, that's what they're there to do. But when they get called at 3 in the morning, because it's so-and-so again, they just transported 8 hours earlier, that's a morale killer. The reason we haven't spent as much time drilling down those numbers on an ongoing basis is that I don't have a lot of resources to address the problem. So we were trying to get funding for social workers, for example, and case managers. We were unsuccessful getting grant money for that. I made a number of presentations, wrote proposals. In a nutshell, they said, hey, you're the city of LA. You can't afford social workers? So it's been challenging. But if you look at the cost of a social worker to start, and it's labor intensive. So you take one super user, say one individual who's called 100 times last year. And particularly if they're housed, okay, do they have insurance? Are they eligible for Covered California, some Medi-Cal HMO? Can we get them into a medical home with an FQHC? Do they have substance abuse issue? I mean, it's labor intensive. I have nobody on my staff. There's no one in the fire department who can dedicate that effort. It needs full-time effort. So to constantly measure it doesn't make sense because I can't fix it right now. And even if I have my APRUs go out, I need to be able to navigate them to a medical home. And I think that's where hopefully some of the, what will be fruitful from this discussion is to follow up to connect the dots with that linkage. If there are FQHCs that can provide medical homes for some of these super users, then it's clearly worthwhile. If the super user is homeless, until you get them, in my opinion, until you get them housed, you're wasting your time. You're just wasting your time because they're not going to take their meds. They have the substance abuse, mental health. It's darn near impossible. We see someone with dual diagnosis and they have diabetes. They're going to be in and out of the ER every other day. It's very difficult. We have homeless alcoholics, transport a couple of times. They get 3 or 4 CAT scans of their head a week. So I would say the low-hanging fruit start with super users who are housed, but I need dedicated social workers / case managers to do that full-time. There's no one to do that right now in our department.
That's a really big issue that potentially we can, at another time, kind of explore and maybe try to help you with that. That's a really big problem. The FQHCs, if they're adults, are not so thrilled in seeing the super users because if they're uninsured, they have to find funds to pay for that, and there's no FQHC that has ample funds laying around. And then the second big problem is even Medi-Cal doesn't really pay for adult visits very well. And so with Medi-Cal reimbursement, unless it's going to be a pretty quick visit, and those patients are never a quick visit because of their multiple issues, that the FQHCs aren't really thrilled about seeing those patients yet either. So what we really have to do from a legislative point of view is really have like some super bonus money going to the FQHCs, in which case then we can get them a home because it's going to be positive cash flow to the FQHCs or the other clinics, so that we can really help them. So I'm not totally sure whether the city could do that or the county could do that or the state of California can do that, but clearly that would be an issue that potentially somebody really has to address. You also mentioned that there's backup sometimes because of the ERs being backed up, and then your staff have to wait there because they can't leave a patient by itself. How often does it happen on a monthly basis or weekly basis?
So the data is not that accurate. It happens just about every day. Not surprisingly, ERs in the more socially disadvantaged neighborhoods are most impacted. ERs in wealthier communities that have a better payer mix can augment their staff and augment beds. So County USC and White Memorial and California Hospital and Centinela, most hours are what we call wall time. We can have resources, and again, it's patients who can't safely go to triage. So they're a fall risk because they're intoxicated. They're at risk because they're potentially suicidal. They're elderly. They having chest pain, things like that. The medics will be on the wall for hours. So it's many, many hours per day. But the data, the way we measure it, I wouldn't give a number. It's not particularly accurate. We're drilling down to that right now. But when we're very busy, our peak period is weekdays, late afternoon, early evening, probably between 3 p.m. and 8 p.m., which is no surprise to anybody. We have many resources that we call are on the wall. And obviously, if they're on the wall, they can't respond to your emergency. Someone else has to respond, which could be life-threatening.
So when they're on the wall, that's really just costing the city of Los Angeles or costing your budget because you're paying people to not use their education and training to the best of their ability. They're basically babysitting a patient that should be seen by the ER staff.
It's one way to look at it. I mean, our members are paid whether they work, whether they're on a call or not. It's an opportunity cost because if someone has a time-critical problem, that ambulance is not available. The more distant ambulance has to respond, and that's it's a huge problem. Again, not unique to LA, and it's most predominant in the hospitals that tend to be busier and a poor payer mix. So if bulk of your payers have Medi-Cal or undocumented, which means they have no insurance, and you're collecting 14 cents on the dollar, you can easily hire more nurses or more doctors.
Right.
If you have mostly commercial payers that pay almost $1 on a dollar, you could augment pretty easily. So we don't typically have wall time problems on the west side, for example, or the West Valley.
Do you have
flu season, we have wall problems everywhere.
Right. Do you have an idea what the total cost to your department is in wall time? I mean, are we talking about $3 million a year? We're talking about $20 million? What are we talking about?
Well, again, I think it depends. If you define cost, it's what's the hour, what does it cost for the 2 paramedics or 2 EMTs per hour times how many hours are on the wall? It'll be millions, absolutely millions. But again, to your point, the city of Las Vegas tried to bill the hospitals based on their hourly cost, but it didn't go anywhere because there was nothing there was no lawful way to do that. So we say cost, it's opportunity cost. It's that those guys, those members are not available to respond to the next call.
If it wouldn't be too difficult at some point, if you could find out, what that annual cost was, it might help us in our report to the city, because potentially there can be some creative way to help you there. I'm not totally sure what it is, but there potentially the city funding extra, nurses to be sitting, or other people to be sitting in those ERs that chronically have the problem.
Yeah, and I think we have made strides. We've partnered with the county, we've partnered with the state. We do have some parameters to force the hospitals to close the ER traffic. Problem is, when one hospital closes, then the next hospital closes. So it's a Pyrrhic victory, to be sure. But again, I'm reticent to give statistics that I don't think are very accurate, but it is a big problem.
We'll accept the fact that they're not accurate, they're the best that you can get, and, we'll put a little star next to that and say this is the best we can do.
And then the LA Times ran a story on this. This was probably about 10, 12 years ago, about the wall time, and it hasn't stopped. But those particular hospitals, it's hundreds of hours per year, hundreds and hundreds of hours.
And then lastly, you mentioned that there's billing for transport, but not billing for runs. Who has oversight over that, or where is the legislation that could change that?
So that's a great question. We've toyed with this idea of what's called a treat no transport, or TNT fee. Several cities have that. So Medicare and Medi-Cal, which includes fee-for-service or HMOs under Medi-Medi, they will not pay for treat no transport, but a lot of commercial payers will. It would change the city ordinance.
City ordinance?
City ordinance would have to change. So as I mentioned, our current ambulance fees are 5 years old, and they're probably the lowest in California. It would basically have to, in the city ordinance, have a separate fee for treat no transport. And the least controversial would not be during a car a fender bender and someone calls 911 and you didn't call for help and they respond, you get a bill. Would be you call, we come out, we evaluate you, and it's pretty easy to define cases where we actually treat. For example, your sugar's low, you're diabetic, you're a little confused, we give you IV sugar, you're better, we don't transport. You should be able to bill for that.
Sure.
And most commercial payers are willing to do that, and they bill for those. They do pay for those services. Other jurisdictions, it would have to be a change in the city ordinance to allow that. Currently, we're not allowed to bill.
Well, theoretically, we're supposed to be able to advise the city council on the creation of city ordinances. So maybe that's someplace we could work with you to do something that would actually help you and also potentially decrease abuse if there are some individuals who are abusing it. So you'd have more resources.
And I think probably the best timing would be, as I understand, the council will be looking at upgrading, or not upgrading, but modifying the ambulance fees, because they haven't been changed in over 5 years. That would probably be the right time to also look at adding a treat no transport fee.
That's wonderful. Any other questions?
A couple of comments. Again, going through the 5 most significant problems addressing EMS. You mentioned a few minutes ago about the 911 911 technology system. I think that's number 6 that I think should be included in there. It sounds like it's a major problem.
Yes, it probably should have been in the top 5. I think that's a great point.
Yeah.
I understand there's one vendor we're incorporating to help use GPS with cell phone coverage, but to your point, yes, the system is absolutely archaic. It truly is. That's a great point. Thank you for that.
And just one last comment regarding FQHCs. By regulation, HRSA regulation, we are required to see everyone that comes to our doors, regardless of ability to pay. We don't turn anyone away. That's a regulation.
It's Public Health Act 330.
Yes. So just want you to know,
Right,
we
no, I
see
understand
everyone.
that. Yes.
And we differ in some ways as far as services hours. We do, at least at our health center, our Royal Vista Family Health Center, Council District 1 and 14. We also have 24-hour on-call service with pediatrician, OBGYN, and family practice or internist. So,
Thank you.
Wonderful, thank you. Any other questions? Dr. Eckstein, thank you very much for presenting to us. Thank you for being so thorough and comprehensive. We really appreciate your service to the people of the city of Los Angeles, and we realize how hard you work, as well as your entire department, and we thank you for that.
Well, thank you for inviting me. Really a privilege to speak with all of you. And any other questions or anything I can do to help, please reach out or email me. Thank you.
Thank you. Item number 2, public comment. Mr. Cohn, or actually Dr. Cohn. I think you have a PhD, don't you? Dr. Cohn.
They gave it to me, I don't know why. My name is Adam Cohen. I'm the Director of Advocacy and Policy Research for AIDS Healthcare Foundation, or AHF. Last month, the Centers for Disease Control and Prevention released their newest STD report. LA County ranked #1 in cases for chlamydia, gonorrhea, and syphilis. About 68,000 cases of chlamydia, 27,000 cases of gonorrhea, and 2,300 cases of syphilis reported just in 2018 alone. An epidemic that is increasing every single year, according to the CDC, and also according to the National Coalition of STD Directors, the executive director of NCSD, stating what we used to do is we had to do more with less, which is the public health approach, and now we are doing less with less. It is simply disturbing that we are allowing this epidemic to rage on, considering that STDs are a comorbidity with HIV. People who contract chlamydia, gonorrhea, or syphilis are at greater risk of contracting HIV. So while the HIV epidemic has essentially stagnated, nationally there are about 38,000 cases every single year, the risk of increasing HIV as a result of not responding to the STD epidemic at the local or national level puts us at greater risk for all the work that we've done over the decades. I hope that the LA City Health Commission I hope that the LA City Health Commission representatives who went to the parks, the Arts Park, et cetera, meeting last month or 2 months ago were able to have kind of a fruitful discussion and also present the report. Thank you.
Any questions or discussion about what you'd like to talk about in future meetings, other than what we've talked about before?
Report. I'd like to incorporate some of what Dr. Eckstein talked about in our commission report.
Sure. That was part of the plan. We left, if you look at the working initial edited versions of the report that is being worked on by our intern, there's a whole spot to continue and update the Dr. Eckstein information. So we're working on that.
Okay, good.
Anybody else have anything they want to talk about? I think the two areas that I think that one would be, are there ordinances that we could recommend to improve more sobering centers, or to help the EMS system be more effective or efficient? Can we recommend in their ordinance to update the billing so they can get reimbursement from some payer, whether it's federal, state, and or private payer, for going out and basically providing health services, rolling either on a truck or one of the new models that we have. More revenue that gets generated, the more resources that we'll have. So potentially we can discuss that at a future meeting. The other thing that I think that we really should talk about is the healthcare proposals that are being discussed on a federal level and how that would impact the city of Los Angeles. And potentially we can invite either representatives of all the campaigns that are currently out there, not saying that they would necessarily want to come, but potentially we can invite them to come to present to us why they think that their particular proposal would be specifically good for the people of the city of Los Angeles.
Especially discuss how we can help with the 911 technology system.
Yeah.
After hearing what we heard today, that
It's a national
you can
problem.
order a pizza has better technology than our 911 system. That's unacceptable.
Agree. Any other questions or discussion?
The issue of the fact that paramedics cannot make a 5150 determination has been battled out in the state legislature a few times, with some groups, particularly physicians, opposing the expansion, because they never want to expand anybody's capacity to do something. But it would be a big help if paramedics could make 5150 determinations and transport people directly to mental health facilities rather than have to go to an ER, which probably doesn't have anybody there to make the determination. So the Board of Supervisors has taken a position with that and conveyed that to their legislative folks. I don't know if the City of LA City Council has done so, but we might inquire as to whether the City Council has taken a position or has been asked to take a position on that particular situation. Because at the moment, as he pointed out, any law enforcement officer can make the determination, but a paramedic cannot. And it really does hamstring things.
So normally, for a legislative point of view, there's always two sides to things. So you're saying that the CMA or the...
CMA has, in the past, as my understanding is, has opposed it, yeah.
Or was it the emergency room physician?
I don't think it was
group.
the ER docs, but I'm not positive of that. For a while, the fire department unions were opposing it, but I believe they've stopped that now. There was some question about whether they were doing it to be friendly with the docs or something, I don't know. But it would be useful to know, you know, in terms of the legislative package from the city, as to whether that's something that they could get behind if they chose to do so. Not us, but the city council.
I'm wondering if we could find out who are the most knowledgeable people on that issue so they could come present to us.
I'll make some inquiries. I'll find out. If you mean in terms of the city or the statewide issue?
Well, from the city, what the city's position is on it. If the city isn't supporting what the county's trying to do, then potentially we can advise and ask the council to support or join with the county and do it.
Right. If the
which
county's
seems-
on board, then the city might want to get on board.
Right, and the question is, you know, from the county, who is, at the county level, the most knowledgeable person, because they can give you resources.
The County Emergency Medical Services Agency is the one that tracks all that. And there's a commission that oversees that, which I'm currently the chair of. It's come up several times, and they follow the legislation. And it comes and goes, and then they amend it and they try again. But at the moment, it hasn't passed.
So is there a government relations individual for the county who is knowledgeable that could give you or us the resources?
The person who runs the EMS agency, named Kathy Chittister, is the person who knows most about it. She reports at each of our meetings about the status of the legislation.
Well, would she be willing to come and explain?
I can't answer for her. I'll find out. I'll be seeing her before too long.
Would you reach out to her, and then also, if you don't mind, find out who the
Whether she'd have someone else come, I don't know.
or a representative from her division, but and also find out who the opposition is, so I could reach out to them, so we can hear two sides of what the debate is.
Yeah.
That would be an interesting
It's
discussion
an
at a future meeting.
interesting issue. I mean, it's clearly caught up in medical politics, you know.
There's a little bit of that. Any other questions, discussion?
Because I lost my mic. Oh, there it goes. For the record, I just wanted to point out that Commissioner Calfani arrived at 6:10, just for the record. And she joined the commission meeting.
And we appreciate you coming. We have to get your badge. Well, seeing no other discussion, I'll ask for a motion for adjournment. Any questions, discussions about adjourning?
Are we having a meeting in December?
We are.
Most commissions don't meet in December.
Usually the commission doesn't have a meeting in December. It's usually dark, but obviously it's, I mean, if there's sufficient amount of commissioners or...
We have the most active members of the commission here currently. Is your desire to have a meeting, or be, even though it's the beginning of December, do you want to be dark for the month for the holidays?
I guess if we have something compelling to hear about, it would be useful, but otherwise.
I'm looking at consensus. It looks like people prefer to be dark in December and have a January meeting. Do I have consensus on that?
Yes.
All right, so then we'll be dark in December, and we'll look forward to a robust January meeting. I wish you then a happy Thanksgiving and wonderful end-of-the-year holidays, no matter what holiday you're celebrating. Thank you.